Okay. I think it's being recorded. So, as I just said, some pediatric things, some other stuff. Basically, lots of useful stuff for exams. Let's start with a spot diagnosis. You can type or you can talk. I don't really mind. It's up to you. Whatever you prefer. Any ideas, team?
I haven't done any peds, but the bowel maybe looks slightly dilated.
Yeah, it does look very dilated. Maddie has gone straight for the diagnosis. This is necrotizing enterocolitis. Maddie, what do you know about necrotizing enterocolitis?
That's a good question. It's more common in premature babies, and they're like formula fed, I think. And essentially, it's like, oh my God, what even is it? Inflammation of the bowel, bad bacteria. You can get like blood in the stool, all this air. Is that enough?
Yeah. Yeah. I mean, that's basically what it is. And it's usually it's more common in premature babies because they have poorly developed like immune function within their gut. So they're more predisposed to developing an infection. And then formula-fed babies are a bit more likely to develop it because you just have a higher risk of infection from formula feeding than you do from natural breast milk, because sure, you can get an immune reaction against milk from the mother, but it's less likely considering the baby's been inside the mother for months and months. It's usually exposed to the same immune related proteins while it was within the mother as it would be while it's being breastfed. So it's less likely if you're breastfed. But yeah, necrotizing enterocolitis is effectively a severe inflammation with superadded infection of the bowel. It's more common in premature babies, and it's such a severe infection that it can cause necrotization of bowel tissue. And I guess like the most important thing is really recognizing clinically how it presents. And Maddie, you said some of the important things, but like a good way to think about a lot of pediatric things is split it into local side effects, then because this is obviously a condition that affects the gut, some GI symptoms / signs, and then on top of that, some systemic signs as well. So locally, what do you think happens in what kind of local features will necrotizing enterocolitis have? So in the local area, where, if you think about where exactly the problem is. So if you examine the abdomen, what kind of things might you notice? Abdominal distension is the number one thing. You'll see that from the end of the bed. And if you were to then palpate the abdomen, Patrick, what do you think it would feel like given what the X-ray on the previous slide looked like? Tense, hard, yes, exactly, perfect. Very good. And then in terms of GI symptoms / signs, Maddie mentioned bloody stools, because generally you've got multiple layers, you have inflammation of multiple layers of the bowel wall, which can cause some blood leakage into the stool. And you've got lots of gas and you've got a very tense abdomen, so you've got pressure buildup in the abdomen. So what other GI symptoms might a baby have? I use symptoms like that because babies can't tell you about them. If you've got lots of pressure down in the lower abdomen, what might you notice in the upper abdomen? Beginning with the letter R. That's already quite common in babies. So yeah, I mean, they can present with shortness of breath as a result of some of these things. They tend to get reflux, yeah, they tend to get reflux type symptoms, and then they can aspirate on that, and then they can get, if they aspirate on any secretions, they can get shortness of breath, respiratory distress. So it is like a multi-system thing. And then the systemic things are kind of the same systemic things as you get with a lot of pediatric presentations. Failure to thrive, hypothermia, bradycardia, hypotension. They're systemically unwell. And remember that in babies, often when they're unwell, they become hypothermic because their thermoregulatory centers aren't completely developed, so they don't mount the same hypothermic response that we do. So yeah, those are like, you guys know how to recognize necrotizing enterocolitis. I think the top three things to remember, and the ones you all got, were tense, distended abdomen, bloody stool, and general systemic upset. Any baby you see with a tense, any premature baby with a tense abdomen, you need to do an abdo X-ray on, because you need to rule this out. So if we talk about management, and oh god, I've screwed up the animations, but what do we think? What do you think you're going to do for a baby who's got necrotizing enterocolitis? So we've defined it, and we've discussed how it's usually due to a premature gut that doesn't have a fully functional immune system. Do we still want to continue feeding through the gut? Excellent. Nil, yeah. So no, we don't want to feed through the gut. So make them nil by mouth. Look at total parenteral nutrition for the time being, because it's still important that they're nutritionally, they have a nutritionally complete input, because they are growing babies, and you give them antibiotics. So TPN, antibiotics, and like there's not really 3 specific antibiotics, but there are 3 groups of bugs that you want to cover. Does anyone have any idea what those 3 groups would be? 3 broad groups of bacteria, like categories of bacteria. Anaerobe is one of them. Jess, what could you give for some anaerobic cover? Gram-positive and gram-negative, very good, yeah. So if let's pretend, yeah, so for the anaerobes, you give them some metronidazole, that will cover that very well. What could you give for gram-positives and gram-negatives? You've got a few options. There's not really a correct option. You would use local guidance, but it's just something for you to revise. Yeah, a penicillin-based antibiotic will cover gram-positive very well. Yeah, and then what antibiotic do we use that covers gram-negative quite well? Begins with the letter G and is bad for our kidneys. Yeah, gentamicin is very good. Very, 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 very good. Good antibiotic knowledge. And yeah, I mean, this is just an example of what you could do. In reality, you could cover gram-positive and gram-negative with something like a cephalosporin. What cephalosporin would you probably want to use? So say you decided to use a cephalosporin instead of a penicillin plus gent. Any idea what you would choose, considering this is a premature baby with immature liver enzymes? Let's see how much antibiotic stuff you remember from 4th year. It's okay if you don't remember it. The chances of this being examined are extremely low. It's just good to continue thinking about things like this. So ceftriaxone, so you kind of fell into my trap, and it's a good idea, but ceftriaxone actually causes biliary sludging in neonates. So in premature babies, you want to avoid using ceftriaxone specifically. You can use cefotaxime instead, because it has less of a hit on the liver, and it's less likely to cause biliary sludging and cause obstructive jaundice. So let me just type that in the chat. So cefotaxime preferable in neonates over ceftriaxone. Just because it's a lot of kef words. So ceftriaxone tends to cause biliary sludging. Cefotaxime is less likely to, so you tend to go with that. So, and the same thing applies for meningitis. If you get if you get a neonate with meningitis, you'd prefer to use cefotaxime over ceftriaxone for exactly the same reason. But as long as you know you're roughly covering 3 broad groups, you'll be fine. Right, that's all you really need to know about neck. What's going on here? What structure are we looking at? What is the actually no. Number 1, what is the imaging modality? Number 2, what is the structure we're visualizing with said imaging modality? Ultrasound is the imaging modality, yeah. And yeah, this is an ultrasound of the brain. And then number 3, what is the finding? Very good. Good. If you're not sure what the finding is, just kind of say what you see. So yeah, this is a hemorrhage into one of the ventricles. Excellent, very good, which is known as intraventricular hemorrhage. This is yet another thing that is more common in premature babies. So when babies have intraventricular hemorrhages, does anyone know where the bleeding originates from? There's one site in particular that tends to bleed. And the reason we can use ultrasound while you think about that is because there's not complete calcification of the skull, and the sutures are still open, so you can still visualize the brain using ultrasound, which is way less radiation than doing like a CT scan. Well, it's basically no radiation. So just remember this, it's a buzzword. I just remember that they tend to originate from bleeding from near the germinal nucleus, which is in the region of the 4th ventricle. The important thing, though, more so than that, what are the complications of an intraventricular hemorrhage? What can happen to a baby if they have bleeding while they're being born? Hydrocephalus, excellent, because you block the blood there can block reabsorption of CSF, so you get increased. You can get a increase in intracranial pressure. Kernicterus is always a complication of any bleeding in babies. Yes, but so you are right, but it's not really a specific complication of intraventricular hemorrhage. Yeah. Yeah, absolutely. You can get if it's a massive bleed, you can lose a lot of blood, which can cause cardiac arrest. Yeah. What else? Motor issues specifically, yeah. So you get damage to the parenchyma, the brain parenchyma, and the cerebrum, which can cause cerebral palsy. Yeah, lots and lots of things. Good. And yeah, the parenchymal damage and hemorrhage is usually due to occlusion of the veins due to the increased pressure, and that basically reduces the flow of blood through the cerebrum. And yeah, so it's effectively like a venous stroke, but because it's in the developing brain, we call it cerebral palsy. Good. And we've already spoken about how it's diagnosed. It's diagnosed using ultrasound. What can we give to decrease the risk of intraventricular hemorrhage, medications wise? Vit-K, very good. And there's lots of guidelines about when you should give Vit-K, when you shouldn't give that Vit-K. Have a read about them. My obstetric knowledge is a bit sketchy since graduating. I'm not going to lie. It's the bit of medicine that I forgot the quickest. Very good. So intraventricular hemorrhage, important. Both of these are possible spot diagnoses they could give you in year 5 exams. So remember what this looks like. Quickly going back to the scan, what line does this baby have? What lines does this baby have? Yeah, there's an NG tube in situ. That's the important one. And there's an umbilical arc line. Good. Very good. Fine. Let's move on to something a bit different. SBA time. I didn't make a Menti think, so give it 30 seconds and write your answer in after that, so everyone has a moment to think. Child is presented to PED with a 7-day fever. You notice cervical lymphadenopathy and some peripheral stigmata. Given the most likely diagnosis, what is the most important investigation to order? So remember, Jordan's gone with D. Okay. D. Cool. Very good. Yes, everyone's gone with D. Excellent. So a lot of these investigations are quite important, but when people say most important diagnosis, I mean investigation, think about what is most likely to change management. What is the underlying diagnosis in this child? This is likely to be Kawasaki's disease, which is a medium vessel vasculitis, often triggered by viral infections or some other driving factor. The echocardiogram is the correct answer. Why are we doing an echocardiogram on this patient? And then how would it change your management of this patient? I think you mean, yeah, coronary artery aneurysms are a complication that you can pick up on an echo. And how does that change the management at all? I mean, we'll talk about it in a minute, so if you don't know, don't worry. Don't worry. Yeah, if they've got involvement of the coronary arteries, you basically have access to more medications that because it's a bit more of an urgent thing. Most patients will hopefully not have coronary artery involvement. So the way I learned Kawasaki disease is I use this mnemonic. I don't know how you guys remember it. So the crash and burn. The 5 days of fever is almost always the key in these questions because the other things can go along with lots of other conditions. So longer than 5 days fever, conjunctivitis, rash, cervical lymphadenopathy, and a strawberry tongue. The hand thing is very non-specific. Like you can get changes to the hand and lots of childhood infections as well. But yeah, that's Kawasaki disease, and then this is what those coronary artery aneurysms really look like. So they are quite significant, and they are at risk of rupture. So it is very important that you're able to recognize and treat these. So complications, coronary artery aneurysms, management. How would you manage a baby? Let's pretend that they have coronary artery aneurysms on echo. So yeah, I think so pretty much most of these patients will be started on aspirin. Yeah. And then if they have coronary artery aneurysms, you want to give them, you might want to consider something else. Yeah, you want to consider IV immunoglobulin. Please don't ask me how IV immunoglobulin works because I don't really understand. I asked a neurologist a couple of weeks ago because I had a patient who was on IVIG for something called stiff person syndrome, and they were like, Anush, nobody really understands how IVIG works, but it works. Anyone wants to explain it to me, you can tell me after. I would love to know. So that's management. And I put a star against aspirin because this is one of the few cases where you use aspirin in kids, which begs the question, why is aspirin avoided in children? And I'll give you a Star Wars related clue. Oh, damn it, you guys all of you knew it before I did this. That's made me very, I mean, good on you. It's just made me a bit sad. Ray's syndrome. Good. And what is Ray's syndrome? What exactly happens? It's encephalopathy that's related to liver toxicity. So yeah, it's a hepatic encephalopathy that's usually due to aspirin, a drug reaction, or a infection, and often it can be a viral infection as well. But yeah, generally avoid aspirin and salicylates when treating young babies. Right. So we've spoken about Kawasaki disease. So something I really struggled with when I was in 5th year was all of the weird rashes in kids, because oh my god, if kids get one thing, it's weird rashes, and they're all in my head, they're all the same, and that really used to confuse me. So let's talk about the childhood exanthems. What is the definition of childhood exanthem? Because this is what they were classically known as, and some people still refer to them as this. There are classically 6 childhood exanthems. Well, 5, but we count up to 6. But they all share something in common, which is this definition. Excellent. Sylvia's effectively hit the nail on the head. An eruptive skin rash associated with fever and constitutional symptoms, and what would you say the commonest cause of a childhood exanthem is, based off what you've learned so far, if you've done your PEDS placements? Viral infections, absolutely, but there are some drug-related ones as well. But yeah, viral infection should be the top of your list. And yeah, as I said, they're classically 5/6 childhood exanthems, and we'll go through them now because they always come up in exam. So, and these were named in the order of which they were discovered. So, any idea what the first one to be discovered was? Also known as first disease. Yeah, all of them have like 3 different names. It's all very annoying. They will not use the weird numbered names in exams, but I think it's nice to know a little bit about the history of medicine. So annoyingly, chickenpox is actually not one of the 6 classical childhood exanthems. How frustrating. And that's because it tends to cause a vesicular rash, which the other ones tend not to cause. Measles was the very first one to be discovered. Yep. It should be part of this. Absolutely. Chickenpox is very important, but we're not going to talk about chickenpox today. Yeah. Yeah, let's sad react that. Where's the sad react? Cool. Any idea what the second one is? Just give me some names. You don't need to know the order in which they were discovered. What are the other childhood viral infections that cause reddish rashes? Scarlet fever, very good. That is actually the next one. Slap cheek syndrome, which is parvovirus, very good. Rubella, which is the next one, also known as German measles. The fourth disease doesn't exist; it was removed. And yeah, so parvovirus is known as 5th disease, or erythema infectiosum, and Rosella infantum is known as 6th disease. So the last 2 are still referred to by their weird numeric name at times. So it's worth remembering. The first 3 are never referred to by their numerical name, so it is absolutely not worth remembering them. And each of these viral infections have some specific, so all of them tend to present with, in their presentation will have a reddish rash around the face and potentially the rest of the body, but there's a few bits in the vignettes that they'll give you that will push you towards one of these over the others. So we'll talk about that now. So here's a few spot diagnoses again. If you had to put your money on one of the 5 diseases, which one would you put it on in this child? Yeah. Why? What is the presentation? Yeah, these are Koplik spots, which are spots on the buccal and mucosa and on the roof of the mouth. Very good. Tends to go along with measles. And then this one. Parvovirus B19, and what's notable about this in particular? Yeah, so it's like a very red rash on the cheeks that is generally spares the rest of the body. So this one is very pathognomonic. Very good. And then if we go back to our diagram of things. So measles, we spoke about Koplik spots. Anything else in a vignette that would suggest measles over another thing? What about the spread of the rash? Where does a measles rash start? It's quite unique to it again. Yeah, behind the ears, very good. Yeah, behind the ears tends to be where the measles rash starts, and then it spreads to the rest of the body. Yeah. Yeah, cephalocaudal. That's the technical term, I think, that I've just learned, that sounds correct. I didn't know that. Yeah, and then with measles, they also tend to get a viral prodrome, so they get the symptoms. The symptoms start before the rash starts, and the important thing is they tend to get conjunctivitis as part of those symptoms. Other things can cause the conjunctivitis, obviously, like Kawasaki's disease, but the Kawasaki will you tend to get less flu-y type symptoms, and also you'll get a much more long-standing fever. But measles is it's actually a very important differential diagnosis for Kawasaki's. And remember that measles is still very much an issue because anti-vax movements are still very much an issue worldwide, so especially here in Western society. Any features in the vignette suggest scarlet fever. One of the clues is if you touch the rash, it will have a very distinct texture in scarlet fever opposed to the others. Yeah, they always say sandpaper rash, where it has a rough texture. Very good. And scarlet fever is a complication of what infection? Yeah, strawberry tongue is a feature of scarlet fever and not a feature of the other things on this list. Group A strep, so it's not actually viral. This one's bacterial, so there tends to be a tonsillitis process going on as well, or they've just recovered from tonsillitis. Very good. And then, like, if you were going to treat tonsillitis to prevent someone getting scarlet fever, what antibiotic would you use for group A strep tonsillitis? In an ideal scenario where you have a very compliant baby, yeah, Pen-V. In real life, you might just give amoxicillin because it's less times a day, and Pen-V tastes disgusting. But for exams, it's penicillin V. Yeah, very good. Rubella has the only notable thing for rubella again is it has a distinct spread. Any ideas where it starts and where it spreads to? Face to feet, yeah. So it's quite linear in its progression. Very good. So face to trunk to then feet. Good. Parvovirus 19 we spoke about. It's a very distinctive look. What is the biggest concern about parvovirus B19 in the in a household that might have a baby with parvovirus B19 infection? Yeah, so if there's someone in the house that's pregnant, that's a concern. Why is it a concern? Yeah, it can cause miscarriage via hydrops fetalis, which is effectively the infection causes shifts in the fluid balance in the, what's the word for growing baby inside? I've forgotten. The baby that's growing inside the womb, effectively there's fluid shifts, so you can get, yes, fetus, that's the word. Oh yes, it's in the name. Sorry, I've had a long day. You say they can get cerebral edema, pulmonary edema, congestive cardiac failure, renal failure. So there's just lots and lots of fluid shifts. Yeah, guys, yeah, I can see you're all very concerned at my lack of knowing this word. I apologize. So that's the important thing with parvovirus B19. So they need to go to the obstetrician ASAP. And then there's one key thing. Thanks, Maddie. There's one key thing about roseola infantum to know. There's two sets of symptoms and they're separated effectively. If anyone understands what I'm saying, that's your clue. So we said that childhood exanthems are rashes associated with constitutional symptoms. Yeah, they can sometimes they'll describe it as a lace-like rash. UCL is unlikely to describe it as that because it's a bit of a giveaway. But so we said it's constitutional symptoms with the fever. It's not. So generally in roseola, the constitutional symptoms will resolve and then you will get a rash. So they're separated in time and space. So they'll have the fever, they'll feel very unwell, it will subside. Potentially, by the time they get the rash, they're often afebrile. Any questions about that before we move on to some prescribing? Go and grab some paper. You can have 2 minutes to grab paper or an iPad or whatever you use to write down. In the meantime, I'll answer any questions that we might have got. Any questions? Concerns? You have 1 more minute to grab paper. Sure. Should we, if it's okay, Jordan, we'll do it at the end. Is that okay? Yeah, we'll do it at the end. So stick around if you want to talk about that. But that is like very examined, so it's definitely worth discussing. Cool. Right. Prescribing. As a general rule, with prescribing, technically, like the stuff you learned in general medicine can come up again because you have geriatric, which and often a lot of geriatric patients are put nil by mouth. So let's start with a year 4 case to get you started. So you've got a 78-year-old gentleman who's had an anterior resection. He's nil by mouth, and the anaesthetist has rang you, handed over the patient from recovery, come back to the ward, and you need to prescribe his maintenance fluids for the next 24 hours. To make your life a little bit easier, I've given you the contents of each of the fluids that you have available to you at the top. So have a think about what you're going to give him. You can have 4 minutes. You'll have 5 in the real thing. And I will use this as an opportunity to tell you that most F1s are terrible at prescribing fluids. It's No surprise that everyone ends up with weird electrolyte abnormalities. I should take a picture of some of the fluid charts that I see on the wards. You'll be very entertained. People go for days without any potassium, and they're like, "Oh, hyperkalemia. Why?" So have a go. It doesn't matter if you've forgotten. We'll go through it again in a minute. This is one of those things that, like, it's just worth knowing all the time because it's just a common situation you might end up in. The other thing I was going to say is, it doesn't really matter what fluids you use in exams, but in real life, you might find that wards only stock certain fluids. So whenever you prescribe fluids in real life, ask the nurses on the ward what they have available, because it's more important that someone has some fluid up than a specific type, and you can always adjust it. In my trust, it's very difficult to find anything that isn't dextrose saline. Yeah, Jordan, dextrose saline is the most available fluid in my hospital by far. It's very difficult to find the other things, actually, bizarrely. But yeah, in exams it makes pick and choose. It literally doesn't make a difference. As long as the numbers kind of add up, you'll be absolutely fine in an exam. Remember that it's not prescribing fluid isn't a science. It's more of an art, and like there's like an endless possible number of correct answers. So you don't need to worry too much about looking for a specific answer. I will illustrate this point in a minute by showing you a very rogue prescription I wrote for this. One more minute. Cool. Does anyone we'll go through how you figure out what fluids you need for revision. But does anyone want to share what they would do? You can just type.
I don't mind. I have no idea if this is right.
Go
But I did. So 1 bag of half a litre normal saline.
So that's okay.
So that's like 75 millimoles of sodium and chloride.
Yeah.
And then I'll say the potassium after. And then 5% dextrose, a 1 litre and a half litre bag.
Yeah.
And then I added 40 plus 20 of potassium to 2 of those.
Yeah. That sounds like a very reasonable prescription. So you've got, so just while I have you can tell us what you need, what an adult needs in a daily fluid prescription.
Yeah, so the water's like, you times their weight by 30 mils.
Yeah, 25 to 30, go with 25 if they're more frail, 30 if they're not. It doesn't really matter in an exam unless they specifically tell you. Yeah.
And then like sodium, potassium, chloride, it's like 1 millimole per kilo per day. But I think it's best to go slightly under with potassium, and you can go slightly over with the other two.
Yeah, so sodium is 1 to 2 and potassium's 0.5 to 1. But yeah, with the potassium, try and stay as close to 1 as possible. Yeah.
And then glucose, is that like 50 to 100?
Yeah, grams? So that's not weight dependent. It's always the same, 50 to 100. And another thing, like, I've seen people go without dextrose for days without any glucose, and people are like, why are they losing weight? Why are they hypoing all the time? So don't forget that dextrose is very important. Cool. That is very good. So there we go. So you're aiming for roughly 72 millimoles of sodium and potassium. roughly 2.1 liters of water and 50 to 100 grams of glucose. This is what I did, which is rogue. So I went with 80 millimoles of potassium, which is a bit risky, but it's probably fine. I've gone with 2.1 liters. I've given a ridiculous dose of dextrose in the last bag. I've given a 1/10 of a 1 liter bag, so the nurses would definitely hate me. So they've got 50 grams from the first bag and 10 from the second bag, so they've got 60 grams in total, which is fine. They've got 150 of sodium, which is fine because it's 1 to 2, and it doesn't really matter with sodium so much. So as long as you've got roughly those numbers, you'll be fine. It literally doesn't matter. You have to, as long as you know roughly what someone needs, you'll get full marks if this ever comes up in an OSCE. You shouldn't worry about it because everyone always constantly worries about it. But as I said, there's not a single correct answer. As long as it's reasonable, you'll get the marks. Any concerns over that? Extra sodium and chloride is generally okay. Well, yeah, but you don't want to consistently give extra sodium. So in real life, if you've seen that someone's consistently getting like 200 millimoles of sodium, like especially obese patients, you want to maybe give them something else for a while instead. As Jordan mentioned, Dex saline is actually amazing. It allows you to give give a fair bit of glucose without giving that much sodium. So you can, in real life, you can use that to balance things out a lot. So I prescribe lots and lots and lots of Dex saline. Please do not use Dex saline to resuscitate people. Only sodium chloride to resuscitate people, please. Very good. Any other questions? So now that we've revised how you prescribe fluids in adults, let's talk about fluids in kiddos. Marcus is 8. He's just had an appendectomy or appendectomy if you're American. Your consultant has requested that you prescribe maintenance fluids for them. Is 28 kilos. What infusion rate will you give these fluids at? We're going to assume there's no fluid deficits or anything like that. We'll cover it another day. It's a bit complicated. Just for the sake of time. So there is a way of doing this that you should have been taught if you've done peds. If you haven't done peds, have a Google, see what you can come up with. You can have until 10 to, so another 4 minutes. Time goes really slowly when you're sat on this side. Just a heads up. So it depends in what context. They will tell you if you need to calculate the fluid deficit or not. The one thing where you will always be asked to do fluid deficit for, if it comes up, is in the context of DKA in a child. You should always calculate the fluid deficit. That being said, as a betting, if I was a betting man, I would not bet on DKA in kids to come up in uroscopy because they want you to pass, and most doctors screw it up. Look over it though. Look over it. We'll make sure we cover it at some point in the next few weeks as well. $70 mils an hour is what Jordan has gone for. Has anyone else reached a calculation? Got the same? Very good. Agree. Cool. Jordan, do you want to run us through what you did?
Sure. So I think the rule is 150-20 rule. So you do 100 mils per kg for the first 10 kilograms, and then you do 50 mils per kg for the next 10 kilograms, and then 20 mils per kg for the rest. So for him, it was 100 times 10 plus 50 times 10 plus 20 times 8, and then divided that all by 24 hours.
Yep, excellent, perfect. And that's all you need to do. And what fluid would you give, Jordan? Do you know what they generally give for kids?
Is it Hartman's?
So I think they usually just go with Dexaline, and then
Dexa.
Yeah, and generally the amount of potassium you put in is something you discuss with a consultant, because kids are complicated and it's always risky. So they generally won't ask you about potassium. In that, it's unlikely that they would ask you much more than a rate. If you saw a kid who needed maintenance fluids, how many bags would you prescribe when you went and saw them? If a nurse is like, "Oh, can you prescribe fluids overnight for overnight as well?" Because just to save the on-call doctor time, would you go and do it for a kid? Yeah. So ideally you ideally you want to review them every hour, and you don't really do full bags of fluids to prescribe. So review. In adults, it's absolutely fine to prescribe. If you're confident, you can go ahead and prescribe maintenance fluids over 24 hours in adults, but technically you should still review after each bag. It's just your workload as an F1 will not allow you to do that. But in kids, it's an absolute no. Review them regularly to see if you need to change the rate of fluids, to see if they still need fluids, because generally fluid balance is very tricky in kids because their vasculature causes a different amount of distribution of water through the various compartments. So keep reviewing. Good stuff. The last bit of prescribing I was going to get you to do is not really pediatric, but it's something that people struggle with a fair bit, and something that people struggle with, like F1 struggle with at work as well, because, and I've noticed that UCL teach it a lot better than anyone else, but they still don't teach it well, which is prescribing for palliative care patients. Yeah, it's not pediatrics, but bear with me. See what you can do with this though. So Mr. Pearson is currently requiring 40 milligrams oral morphine twice a day. He's finding it very difficult to swallow tablets. Can you convert them to a syringe driver and prescribe anticipatory medications because you think he is nearing the end of his life? So not all of you will have done palliative care, but palliative care prescribing is an OSCE station that you can absolutely score full marks on very, very easily. And once again, there's lots of options. There's not like a single correct answer. You just need to meet certain criteria. So I'm going to give you 3 minutes for this one. Okay. 3 minutes from now. 5 minutes left of your scheduled meeting time. I don't know what that means. I presume it's not going to stop. Anyway, there are 4 categories of drugs that a dying patient needs. Does anyone want to tell me what they were taught or what they think there should be? One of them is on the slide. Analgesia is on the slide. Yeah, excellent. Jess has gone right in with all 4. So analgesia, something for anxiety, something for sickness, and something for secretions. So there's 4 categories of drugs. That doesn't necessarily mean you need four drugs, because certain drugs will hit more than one of these. So and when you start work, there'll be trust guidelines on what you should and shouldn't prescribe. And if you're lucky and have electronic prescribing like we do, there'll even be a protocol for you to just click on and it will prescribe them for you. But it's good to know. So those are the 4 anticipatory medications. I've got these slides in the wrong order. So analgesia, like if they're palliative, it's going to be morphine or an alternative. In what situations would you use an alternative rather than morphine? There's basically one big reason to not use morphine. Poor renal function or an allergy. Yeah, it's usually renal function in dying patients, but I have seen people with morphine allergies, or the options instead of morphine for pain analgesia in renal failure. So there's an option if they've got poor renal function, and then there's an option if they've got no renal function. Yeah, exactly. So oxycodone is better if they've got chronic kidney disease. If they're in end-stage renal failure, alfentanil or fentanyl tend to be better. Very good. Anxiolytic, you can use haloperidol, or you can, which is an antipsychotic, or midazolam, which is a benzodiazepine. For secretions, you can use, there are 3 main options. You can use hyoscine hydrobromide, also known as, wait, no, I can't remember which of these is buscopan. One of them is buscopan. I think it might be butyl bromide. You can use hyoscine or you can use glycopyrronium. Some people will say glyco is better for respiratory, hyoscine is better for gut, but like the fact is you just need to give them one of these. It doesn't really matter so much. I think the evidence on that is a bit sketchy. And then lastly, you need an antiemetic. And again, haloperidol is a very good antiemetic, and it's in italics because you can see it hits 2 of these groups together. What other possible antiemetics could you use other than haloperidol? I don't know why I've only put haloperidol on this slide. Cyclizine, yeah, very good. In what patients might you not want to use cyclizine in? Metoclopramide, yeah. Sometimes it's dangerous because, especially if it's a cancer patient with obstruction, careful with metoclopramide, but yeah, it's a good option. So in what group of patients do you really need to avoid haloperidol, and in what group of patients might you want to avoid cyclizine? Heart failure, yeah, is a contraindication for cyclizine, but if they're end of life, then you might still use it. But yeah, I wouldn't, if it's in an exam, try not to. Yeah. What about for, yeah, haloperidol, don't give for Parkinson's because you can make them rigid and they can have a Parkinsonian crisis. Good. So what did people prescribe? I'm very curious. Any volunteers? So I guess, should we start with the morphine? So you've got 40 milligrams twice a day of oral morphine, and you want to convert that to a subcut morphine. So what's that in terms of subcut usage? Yeah, so he's using 80 milligrams of morphine in total every day. Subcut is twice as potent as oral, so you halve it. So he needs 40 milligrams through his syringe driver. You can still have PRNs on top of that. So if you take an eighth of 40, you can have 5 milligram injection subcut as a PRN dose as well. But you're not required to prescribe that for this station per se. Fine. And then you can give some of the various other drugs in the syringe driver to cover other things. So I've given some haloperidol and some hyoscine butyl bromide. And on the Good Hospital drug chart, this is kind of how you want to prescribe it. There's lots of different ways of prescribing it. Whatever they've taught you this year was probably the most up-to-date one. So have a look at it and choose what you want to prescribe. I've chosen some high doses of stuff. It doesn't really matter what doses you choose, just pick something out of the BNF. Notably, if this patient was still very anxious despite the syringe driver, your options are increase the haloperidol, or you can add in a benzo like midazolam into the syringe driver. So again, there's no correct answer, but there's different options as to what you could do. Does that make sense? Just make sure you cover these 4 categories. That is the most important thing. You titrate to. They're not really weight-based. I think they're just, I mean, generally you'll give a higher dose to a bigger patient, but it doesn't really matter, and you'll titrate it according to their need. Often what you'll do is you'll start someone on anticipatories, and then the palliative care team will come and review it, and based on their symptom control, they will change the doses to what they think is best. Right, so that's everything I was going to cover today. I'm going to just put the feedback form in the chat, and then I'll stop the recording. If you could fill it out, and then I'll cover the VZV, the varicella stuff, and then I will. And then, but before that, I'll answer any questions anyone might have. Let me just find the feedback link. That is not the feedback link. Give me a second, guys. Copy link. Please fill it out. Fine.